Dr. Vicente Torres is a world expert in PKD from the Mayo Clinic. He'll be talking about, his topic is on practical guidelines for treatment with V2 receptor antagonists in ADPKD. Dr. Torres.
Thank you. Well, thank you, Dr. Pei, for the invitation to this excellent meeting and also for your very, very kind hospitality. It's always a privilege to come here, so thank you very much. And these are my disclosures. And as you all know, tolvaptan has been proven to be effective in 2 large clinical trials to slow down the progression of polycystic kidney disease. And this has led to the approval of tolvaptan in many countries for the treatment of polycystic kidney disease. However, the indications change from country to country and are somewhat vague. Like, for example, in the European Union and in the United States is indicated for patients that have rapidly progressive disease. But what rapidly progressive disease means is not clearly clarified. In addition, tolvaptan is a very powerful medication producing a high increase in urine output. And there are some considerations to be given to the patients and before starting the treatment. And many physicians, most physicians that have not been involved in the clinical trials don't feel confident with tolvaptan. So for this reason, a number of investigators that participated in the clinical trials of tolvaptan decided to discuss recommendations and get a consensus and provide some guidance to nephrologists on how to use tolvaptan. And we published this paper in JSON as a practical guide for the treatment of patients with rapidly progressive disease. And there were 10 points that are considered in this manuscript. The first one is to confirm the diagnosis of ADPKD, and that seems quite an obvious thing, and usually most of the times the diagnosis of ADPKD is quite obvious, but is not always the case. In this slide, it shows cases of patients that have been diagnosed with ADPKD and that were enrolled in different clinical trials, and not a single one of them has ADPKD. So they have a diagnosis of ADPKD caused by uromodulin mutations or MUC1 mutations or HNF1 beta, or more recently the new gene DNAJB11 that causes a disease that is kind of intermediate between ADPKD and autosomal dominant tubulointerstitial kidney disease. So it is important to be sure that the patient has ADPKD. The second thing is to confirm that the disease is rapidly progressive. And in our opinion, the best method to use is to use a height-adjusted total kidney volume along with the age of the patient and the estimated GFR. And actually, this is what has been, as you have already heard from Dr. Perron, approved by regulatory agencies in Europe and the United States and Canada as a prognostic indicator. Now, the imaging classification of ADPKD was developed as a tool to really apply this prognostic indicator to the patient in a way that was easy to do. And in this tool, the first thing is to be sure that you apply this classification only to patients that have typical autosomal dominant polycystic kidney disease. There's about 5% of the patients we see in the office that have atypical autosomal dominant polycystic kidney disease. And these patients that have atypical autosomal dominant polycystic kidney disease, as you already heard from Dr. Halali, are patients that have either unilateral, segmental, or lopsided disease. And usually these are patients that have perfectly normal kidney function. And also there is a subset of patients that have ischemic changes, and that usually are elderly or older patients. And in these two situations, total kidney volume cannot be used as a prognostic indicator. So the Mayo classification applies to the patients that have typical polycystic kidney disease. We divide these patients that have typical polycystic kidney disease in 5 groups of increasing severity. And these 5 groups can be, or the classification, the class can be decided with a single measurement of height-adjusted kidney volume and the age, and assuming a starting height-adjusted kidney volume, normal height-adjusted kidney volume of 150 mLs per minute. So these 5 groups in the class A, the rate of growth is estimated to be less than 1.5% per year, and class B is 1.5 to 3, and so on until class E, that is over 6% per year. And you have some typical images of class 1A, 1B, and 1D, 1C, and 1E on the side of the slide. Now, this classification, together with the age of the patient and estimated GFR, can be used as a predictor of the future decline in GFR. And that's what the slide on the left, or the panel on the left, shows. And this can be done with pretty good accuracy, with an expected predicted error of about 10.5% in patients that have an eGFR of less than 60, and a little bit higher in patients that have eGFR over 60, because at this over 60, the eGFR is much noisier. Also, the classification predicts the age of end-stage kidney disease in patients that have class 1C. And the age of end-stage kidney disease is about in the mid to late 50s. Patients with class 1D is in the early 50s. Patients with class 1E is in the late 30s or early 40s. So this is a good predictive indicator. So what we recommend in terms of progressive disease is that patients that have class 1A should not be treated because they have a good, excellent prognosis. There is only one patient in the Mayo series that had developed end-stage renal disease, and that developed end-stage renal disease due to chemotherapy for cancer and had nothing to do with the polycystic kidney disease. Patients with class 1B also have a low risk. And in this patient with class 1B, what we recommend is to follow the patients conservatively and see whether they behave as class 1B in the future, but we do not recommend starting treatment. Patients with class 1C, D, and E are the patients that we recommend treatment with tolvaptan or any other disease-modifying therapies that may develop in the future. So we have an application which is easily Googleable just by Googling ADPKD classification, where you can include the maximum dimensions of the kidney, both on the sagittal and coronal views, and then the transverse and anterior-posterior dimensions. One thing that is important is to realize that the sagittal length of the kidney can be significantly higher than the coronal length of the kidney. So it's important to have the sagittal length. If you don't have the sagittal length, you can use 2 coronals instead of the sagittal, but that introduces a significant error because the sagittal length, especially in polycystic kidney disease, can be quite slanted, and the sagittal length can be considerably higher than the coronal length. So with this information, you can include this information, and that gives you the class of the patient. In this particular patient would be class 1E. And then if you add the gender and race and the serum creatinine, that estimates the GFR. And also if you want to see what the GFR would be sometime in the future, like 4 years later, this app gives you an approximation of what the GFR will be 4 years later, the future. So what is important also is that in patients that are young patients, a very small difference in the estimation of the volume can classify the patients, can put the patients in class B that would require no treatment, or class C where the treatment would be indicated. So in patients who are very young patients, you may want to have more accurate measurements of kidney volume rather than relying only on the ellipsoid equation. And in these patients, probably you want to use the gold standard, which is planimetry on the right, which is time-consuming, is laborious, but has some other advantage because it segments the kidney, so you can do some other, get some more information from using color analysis, or you can use stereology, which is a little bit faster than the planimetry. And more recently, you can use a fully automated total kidney measurements using a software which has been derived using artificial intelligence, and this gives you a very accurate measurement with really very small errors compared to the gold standard of planimetry. At Mayo, we have now in working, so in our patient that we see with polycystic kidney disease, automatically they get the total kidney volume using this automated method. And there is a project together with the PKD Foundation on making this software and available in other centers as well. So in addition to the total kidney volume, another way to do prognostication is using the genotype. And this shows the work of Dr. Cornec-Legol in France, showing that the patients that have PKD2 mutations have better prognosis than those having PKD1 mutations. And in the PKD1 mutations can be subdivided into patients that are having truncating mutations and non-truncating mutations. And the non-truncating mutations have a prognosis that is intermediate between the truncating mutations and the PKD2 mutations. More recently, the patients that have non-truncating mutations or missense mutations have been subdivided into weak mutations that behave more like PKD2 mutations and strong mutations that behave more like PKD1 truncating mutations. But as you can see in this slide, there is quite significant overlap based on the genetics alone. Now, there is work done here from Dr. Badua that show that you can have a good guess of whether the patient will have a PKD2 mutation or a PKD1 mutation if you have a family history based on the age of end-stage kidney disease in other family members. So if there is a family member that has still some kidney function above the age of 68, it's likely that this patient will have a PKD2 mutation. If a family member has got end-stage kidney disease below the age of 58, it's likely that will be a PKD1 mutation. And then some clinical information has been incorporated into the genetic information in the ProPKD score, and developed by Dr. Cornec-Legol, where it may increase a little bit the predictive value of the genetic testing. However, this ProPKD score requires that the patients are at least 35 years of age, or that they already have had the clinical manifestations that increase the score. And this may be a problem because in prognostication, you want to be able to prognosticate severe disease or rapidly progressive disease as early as possible and not to have to wait until age 35. Now, the genetic information is a very good predictor of the progression of the disease, particularly in populations of patients. However, in individual patients, it's not absolutely 100% reliable. For example, all these patients in this slide are patients from the CRISP study at baseline. And the patients that have very severe disease, which circled in red in the bottom, at the bottom, these patients all had PKD1 truncating mutations. And the patient in blue above had a PKD2 mutation. And most patients with PKD2 mutations have mild disease, and most patients with PKD1 truncating mutations have severe disease. However, these three patients have PKD1 mutations, two of them truncating mutations, and still have mild disease. So having a PKD1 truncating mutation by itself is not sufficient in an individual patient to be confident that the patient will have rapidly progressive disease. That's why genetic genetics alone, without anything else, in individual patients are not 100% reliable. Now, this is the European algorithm proposed to define autosomal dominant polycystic kidney disease. Now, this algorithm is useful, but has some serious limitations. The first one, this algorithm requires, first step is that the patients have a certain range of renal function for certain ages. And after that, to have at least one of the following criteria down below that in order to be defined rapidly progressive disease. The problem, as you can see in the patients that are ages 30 to 40, if they have a GFR that above 90, these patients are defined as having not having rapidly progressive disease and therefore would not be treated. And patients who are over the age of 50, if they have a GFR above 60, are classified as not having rapidly progressive disease. And this is not correct. If you look on the left side, in the CRISPR study, we had, I cannot read very well, 30 patients that before the ages of 30 and 39 that had a GFR above 90. And we have about 45 patients with ages before 40 and 50 that had a GFR above 60. Of these, 50% in the first group and 42% in the second group had image classification class C or E. So based on the image classification, be rapidly progressive. And we have followed these patients already now for 15 years, and 4 patients in the first group and 10 patients in the second group have already reached end-stage kidney disease. So this shows that this first step in the ERA classification is not completely reliable. The other steps also have problems. First one is the historical eGFR decline is a problem because above age 60, the eGFR is very noisy and you cannot really rely very much on a decline of GFR above this level. And then there are historical factors that may have an effect on GFR that are unavailable retrospectively quite often in the clinical history. So that's a problem. Historical TKV increase is also a problem because very few patients have 3 or more MRIs or CTs that are necessary to determine the rate of increase on kidney volume, clinically speaking, and also requires precise measurements. You cannot do that based on ellipsoid equations, so that requires a significant amount of work. The atypical cases are not excluded, and also it is important to remember that the rate of increase in total kidney volume is the same in patients with PKD1, same patient with PKD2. So the CRISPR study showed that there is a difference in total kidney volume between PKD1 and PKD2, but the rate of increase is not different. So that would not separate patients with mild disease with PKD2 from patients with more severe disease like PKD1. The other criteria has been the length by ultrasound over 16.5 centimeters. But in addition to the ultrasound being very operator dependent, the 16.5 centimeter cuts doesn't work because there are very young patients, 18, 20, 25 years old. The kidney length will be less than 16.5, but if you do the kidney volume measurements, they qualify as class C or D. And on the contrary, you have a typical patient that may have very long kidneys that also would be atypical, and the ultrasound length would not qualify. And then the restriction with the PKD, pro-PKD score is again the age of 35 years. So based on the prognostic indicators we have, the best one and the only one that has been accepted by regulatory agencies is total kidney volume along age and eGFR. And the image classification is just a practical tool to utilize this. The genetic ones are correct most of the time in populations, but may not be in an individual level. And the ERA-ADT algorithm is workable, but it's complicated and not always accurate. And then we have chemical biomarkers like SUPAR and MCP1 and some other markers that have been shown to be usable but lack external validation and have lower specificity for polycystic kidney disease, and then have more advanced imaging biomarkers like texture analysis or cyst, parenchyma surface area that are not widely available, so they will be not very practical at the present time. So once you have gone through these first two steps, the third step is to ensure the implementation of basic protective measures. So there are things that we have already shown to be helpful to slow down the progression of the cystic disease based mostly on the HALT study. And these are blood pressure control, hydration, moderate sodium restriction, and maintaining a low BMI and maintaining a low cholesterol level. So all these things, I think, should be implemented. It doesn't make sense to treat a patient with tolvaptan if this is not implemented at the same time. So first, the easy things have to be done, then have the more complicated things afterwards. Then the patients need to get balanced information about the potential benefits and harms of tolvaptan. The benefits are slowing the kidney growth, slowing the eGFR decline, the possibility that they delay the need for renal replacement therapy. It reduces pain, hematuria, and stones and urinary tract infections according to the TEMPO trials. Anecdotally, there are some patients that have chronic pain that the chronic pain has gotten better or subsided with the tolvaptan, and there is a slight reduction in blood pressure. The harms, of course, are polyuria and nocturia. There is a slight uric acid elevations. Transaminase elevations are the main concern, occurring about 5% of the patients, but there is a risk for severe hepatocellular injury, and therefore there is a REMS program, and these patients need to be very closely monitored. And there is possible interaction with other drugs that are cytochrome P453 inhibitors. Now, based on what we know from TEMPO 3-4 and REPRISE, one can predict what the benefit of treatment would be. Benefits from treatment are slightly better if you use the REPRISE study than the TEMPO 3-4 study. The reason for that is in the TEMPO 3-4 study included patients with early disease, and many of the patients with early disease actually didn't have a decline on GFR because they were still at the area of the progression of the disease where the GFR is normal, so you would not expect to have a benefit on eGFR. The average benefit in eGFR in TEMPO 3-4 was 1 ml of GFR per year. The average benefit on GFR delay in the REPRISE study was 1.27 mL per year. So that's why the data with the REPRISE, the extrapolation with the REPRISE look a little bit better than the extrapolations with TEMPO 3-4. We believe that these extrapolations are reasonable because in a post hoc analysis that we have done with the Mayo patients, in patients that have been treated for up to 11 years, we have shown that this benefit of a yearly benefit is cumulative over time, and it does not wane with time. So based on these extrapolations, you can if you start treatment when the GFR is 60 or above, you may be able to delay the need for renal replacement therapy for as much as 7 years, so which is a significant delay. Now, it's important also in giving this information to the patients to note the results of REPRISE, where the benefit in patients over the age of 55 years was not significant. So the benefit was only in the patients that were younger than 55 years. The reason for that was that the patients that participated in the REPRISE study that were over 55 years of age, the rate of decline of kidney function was only about 2.5 mL per year, which is only about double what you would expect by the just aging alone. And there was the benefit was not demonstrated or was not existent in these patients over 55 years. Also, what you can notice that the benefit was most important in the patient that had CKD stage 3A rather than patients that have CKD stage 3B or stage 4. So because of that, we believe that elderly patients that have already advanced CKD are unlikely to benefit from therapy. We cannot rule this out completely, that on the long term they could have some benefit, but usually we do not strongly recommend, at least not strongly recommend treatment in this group of older patients that already have quite advanced disease. Now, there are exclusions to treatment with tolvaptan. Of course, pregnancy and breastfeeding, significant hepatocellular liver disease other than polycystic liver disease, inability to sense thirst or urinary tract obstructions, which is more of a problem in elderly patients, and strong cytochrome P450 inhibitors. Now, it is important for the treatment to be successful on the implementation that the patients are really very well educated about what to expect, so they are not caught by surprise. It's important that they understand that they will have polyuria and nocturia. This is more of a problem initially during the first few weeks. Once they get used to that, there is also some reduction in the amount of polyuria, but also they get used to that and it's less of a problem. In the clinical trials, we had to start at a fixed dose. In practice, we recommend starting at 45-50 milligrams, which is the same level that was used in the clinical trials, but if patients don't tolerate that, we have no problem in going down to 30-15 or 15-15. Patients need to understand or need to expect that they will see initially a reduction in GFR that will occur immediately, so they are not surprised when that happens, which happens in most of the cases. And this is due to the stimulation of tubuloglomerular feedback. They should expect a slight increase in serum uric acid. The average increase in serum uric acid in the CRISPR study was 0.8 milligrams per deciliter compared to 0.2 milligrams per deciliter in the patients treated with placebo. And about 2.9% of the patients treated with tolvaptan develop gout as compared to 1.4% of the patients treated with placebo. And also they may need to adjust the antihypertensive therapy. So that I think is important, at least for the nephrologist, taking care of the patient to understand why the GFR goes down, starting tolvaptan, and that's due to the fact that the vasopressin normally suppresses tubuloglomerular feedback, and suppresses tubuloglomerular feedback by reducing the concentration of sodium at the level of the macula densa. And this is due to the fact that the vasopressin increases the recycling of urea from the collecting duct to the thick ascending limb of Henle. And since the thick ascending limb of Henle, when the osmotic pressure increases due to the recycling of urea, that retains water in the thick ascending limb of Henle, which is impermeable to water. And also it reduces the sodium concentration there because the vasopressin stimulates the reabsorption of sodium by the thick ascending limb of Henle. All of this results in the reduction of sodium at the macula densa, which results in efferent vasodilatation through stimulation of the renin secretion, efferent vasoconstriction, and that increases the GFR. And what tolvaptan does is reverses all of this. So as a result of that, GFR immediately, when you treat the patient with tolvaptan, reduces the GFR. When you stop the tolvaptan, the GFR goes back up. Now, after deciding that the patient needs treatment, then you start the treatment, and again, we started treatment with 45-15, but in clinical practice, I don't think there is a strong reason to push the treatment all the way to 90-30, provided that the trough urine osmolality is consistently below 280 milliosmoles per liter. There is no evidence that going down further is helpful. Actually, in a post-hoc analysis done by Olivier de Vuist, where correlated the urine osmolality, the trough urine osmolality at the end of the titration of tolvaptan, there appeared to be no benefit when the urine osmolality went below 250 on the benefit of tolvaptan during the trial. Now, another thing that needs to be done is to implement the REMS program At least that is mandated in the United States, so the patients should have liver function tests, transaminases and bilirubin at 15 days after starting tolvaptan and monthly after this for the first 18 months. And we like also to measure urine sodium and plasma sodium and the plasma creatinine. The plasma sodium, because it helps to adjust the medication, we want to maintain the plasma sodium in the normal range and as close to 139, 140 as possible. If it goes below 135, then the patient is drinking too much water and should slow down. If the if the plasma sodium goes up above 143 or 144, 145, the patient is getting dehydrated, and either they have to drink more water or the dose of tolvaptan should be reduced. The creatinine is also helpful because if we can accept an increase in the serum, a reduction in GFR of about 10%, 20% at the most in patients that have normal kidney function to start with, but not beyond that. If it goes beyond that, then we have to adjust the medication or stop it for a while. Now, there are some practical recommendations to start the medication on a rest day, on a weekend, when they can go to the bathroom frequently, certainly not before going to the car and going back home 200 miles away, because that creates a lot of problems. They have to be instructed to drink enough water to prevent thirst. It's very important to avoid fluids that contain high sugar or fat content. At least they should drink 2 to 3 liters daily, but they have to be instructed that they should drink during the night, if 1 or 2 cups before going to bed, and again when they wake up if they have nocturia, which is always the case. Dietary changes to reduce daily or smaller loads, as you have already heard earlier. And in patients working in conditions hot conditions that may lead to dehydration, they should not be taking the medication at that time. When elevations in liver enzymes occur, if the elevation in liver enzyme is more than 3 times the upper limit of normal, the medication, and there is no other reason to explain it, the medication should be discontinued permanently. And then the other thing that is important is to try to monitor the treatment efficacy. That's something that the patients ask. Patients ask, well, how do I know that tolvaptan is doing any good to me? And actually, I have a case that happened just last week when one of the patients asked me about that, so I'll go through the way that one can do that. This patient is a 38-year-old woman that I saw for the first time about 12 or 13 years ago. Had a diagnosis of polycystic kidney disease when she was 32 years old. This was done, or 22 years old. It was done when the mass was felt on GYN examination. There was no family history available because she was adopted. Had a serum creatinine of 0.9 milligrams per deciliter with an estimated GFR of 81 mLs, a height-adjusted TKV of 1,987, which put her in image classification 1E, and she had a PKD1 truncating mutation. And the black dot there indicates where she is in the classification, class E. And these are her kidneys at baseline. Very severe polycystic kidney disease. Though she was class E, so she had, by definition, based on class E, a rate of progression that was above 6% per year. Between 2008 and 2009, I believe, had a rate of increase of close to 9% per year. Between 2009 and May 2011, actually in February 2011, she was enrolled in the modified release tolvaptan trial. That was a trial of a 1 month duration, during which she was randomized to tolvaptan. So she was taking tolvaptan at that time, which that might have influenced the rate of increasing kidney volume, because when she had the baseline kidney volume for the Tempo 271 study, the estimated rate of progression of rate of increase of TKV was a little bit below 6%. During the first year of Tempo 271, the rate of increase of TKV went down to about 2.2%, and then increased, but it was maintained consistently below 6%, and most of the time below 5% per year. So in terms of the annualized total kidney volume growth, you could see that there was some beneficial effect. You can also plot the kidney volume, and you see that the point was a little bit closer to class D than was before. Not impressive, but that's a logarithmic scale, so a little bit closer to class D than it was before. And then the other thing you can do is to estimate, based on the app that we have, is what the progression of, and when I saw her was on August 28, and you can estimate based on the kidney volume that was measured in March 2008 and in May 2011, what the estimated kidney volume would have been on August 28, 2019, and the estimated eGFR. You can see, based on the kidney volume measured in 2008, the estimated GFR now would have been 16.3. Based on the kidney volume measured in 2011, the estimated kidney volume, the estimated GFR would have been 21.3, but actually the measured GFR was 47.7, and that was while taking tolvaptan that kept the GFR a little bit down. So without taking the tolvaptan, it might have been a little bit higher. So that's a clear benefit. Of course, it's a clear benefit based on our predictive equations that are not 100% proven. But that's a way that one can estimate whether the tolvaptan is doing something or not, which is something that is important for the patients to know. So that's, I think, my presentation. I have these questions here. So the first one is, which of the following is the most helpful for the nephrologist in deciding whether to recommend treatment with tolvaptan to a patient with ADPKD? First is the reported kidney length by ultrasound, and the reported measurement of TKV, the direct examination of abdominal MRI by the nephrologist, the results of genetic testing, or having the estimated GFR. Mm-hmm. That's not what I wanted. The answer here, in my opinion, is to have the directed examination of the abdominal MRI by the nephrologist, because you can have a reported total kidney volume of an atypical case being 4,000, and you should not treat that patient. So I think the nephrologist should check the MRI himself, and then have the reported value from the radiologist is great, if you have it. If you don't have it, you can measure it yourself using the ellipsoid equation, but I don't think you can rely on what you see on a piece of paper without looking at the MRI. So I think the most important thing is to look at the MRI. So, sorry I was not clear enough. The next question is, in the countries where a vasopressin V2 receptor antagonist has been approved for the treatment of ADPKD, which of the following patients is likely to derive the most benefit from treatment with this drug? A 55-year-old man with a height-adjusted TKV of 300 mL per meter, a 35-year-old woman with a PKD mutation and serum creatinine of 0.9 milligrams per deciliter, a 30-year-old man with a height-adjusted TKV of 1,200 and serum creatinine of 0.9 milligrams per deciliter, a 70-year-old man with serum creatinine of 2.6 6 milligrams per deciliter, or a 40-year-old woman with a TKV of 1800 and 3 cysts accounting for most of the volume. So 3 cysts measuring 520, 464, and 285 mLs. Okay, well, that's great. Well, thank you very much for your attention.